speaker today, Dr. Saffrullah, Wazeer, and our sponsors from Sipla, Tiran, Manula. Thank you, and all the guest invitees. There are a few announcements. Actually, we planned for a foreign trip, but no one was interested, so only COP people. If anyone is willing to proceed with this, please mention in our WhatsApp group. Without taking much time, I try to introduce the speaker today. Dr. Saffrullah Wazeer, consultant ENT surgeon and head and neck surgeon at Sirimavo Bandaranaike Specialized Children's Hospital, Peradeniya. He has 17 years of clinical experience as established independent government practice in central Sri Lanka. Skilled in general otolaryngology and adults and children. Special interest in head and neck surgery, pediatric otology, and cochlear implants, which are much taking time. I invite Dr. Saffrullah to proceed the lecture today.
Good evening, and at the outset, I'd like to thank the organizer, Sipla, Sri Lanka, Tiran, my good old friend, and thank you for the Hill Country Doctors Association for having me over. And it's very heartening to see most of the faces who are known to us. I think I've known them when I was a trainee here. So, and we have had, I think I know most of them, and it's really nice to see them. So they know me, so there's no introduction needed. And so I thought I'll talk to you on some aspects of allergic rhinitis, which is very common, and in your general practice, most of the time, it's 40% will be pediatrics. And of the pediatric issues, you see rhinitis, rhinosinusitis very commonly, acute and chronic. So if you have a good grip of it, you would know how to go about things. So I'll take you through it. And if you have any questions, I'll be happy to answer at the end, or you can ask me in between. So without further ado, let's proceed with an overview of allergic rhinitis and respiratory allergens. Okay, so we look at the pathophysiology, comorbidities, and management of allergic rhinitis, and something about antihistamines we usually use. So the term rhinitis, we do see if children come to you with rhinitis of various etiology. So it's a symptomatic disorder of the nose characterized by itching, nasal discharge, sneezing, and nasal airway obstruction. But in allergic rhinitis, the induction of rhinitis is a symptom of after allergen exposure. And if you go back to your medical school days, it's more of IgE mediated. So that causes the inflammation of the mucosa and all the consequences. So there are some other phenotypes people talk about. What we'll be concentrating on is allergic rhinitis, but you should remember that there are things which are not allergic, that is infectious, like after a viral infection or bacterial, and you do get some fungal rhinitis as well. And there's another entity called non-allergic, non-infectious rhinitis. Sometimes they call it vasomotor rhinitis, and non-allergic rhinitis with eosinophilia syndrome, and chronic rhinosinusitis with polyps, right? So these are not common, but you do come across. Okay. So why talk about allergic rhinitis? So if you are given a list of conditions including asthma, respiratory infections, stress, migraine, where would you rank in terms of mean productivity loss or employee per year? Which we think is causing more morbidity of all these conditions, which you will come across in your practice. Migraine you see very often, stress of course yes, and respiratory infections as well as allergic rhinitis. Any guesses? Allergic rhinitis is the number one uh, in this list. So how common is it? The epidemiology. It occurs in about 20% of the general population, and very common in asthmatics. Around 80 to 85% of the asthmatics will have allergic rhinitis. And if you are a patient with an allergic rhinitis, you have about threefold risk of developing asthma. So if you take asthma alone, occurs in roughly about 5% of the general population, and allergic rhinitis occurs in about 50% of the patients with asthma. So if you see a patient with allergic rhinitis, there are high chance of you detecting bronchial asthma. So please put your stent on and listen to the chest. You will find signs and symptoms which will help you diagnose. So we surgeons hardly carry a stethoscope, but better to have a stent. And if you suspect allergic rhinitis, you have to auscultate the chest as well. That's a take-home message. So they come with the common symptoms of sneezing, runny nose, itchy nose, obstruction. So don't stop at allergy. Just put a stent. You will sometimes, most of the time, you will diagnose something else as well. So that's one take-home message for you. I wanted to tell you so that it's up to the morbidity of the patient and the care, the productivity, and their lifestyle. Okay. So what's the pathophysiology? It's an inflammatory disorder of the nasal mucosa characterized by itching, sneezing, rhinorrhea, and nasal congestion. So the impact is on school life, social life, as well as work productivity. And if the severity is more, the effect on your activities of daily living is much higher. So the loss of productivity, missed school and work days, and direct costs associated with treatment create substantial costs to the society. So they have to pitch in a huge amount. So basically the symptoms, you get ocular symptoms. Sometimes they come with allergic conjunctivitis. Some people complain of a sore throat. So though this is not a lecture on sore throat, I'm going to tell you, many people come with sore throat. So don't take it as a tonsillitis, right? So if the patient is symptomatic at that time, have a look at the throat, right? And ask them whether this is the worst case scenario that you are looking at. If it is tonsillitis, you will see congested tonsils with yellowish spots, fever, lymph nodes, and things like that. How it is a full-blown pharyngitis due to viral cause, again, you see the inflamed erythematous mucosa. But otherwise, the sore throat will be due to allergies and other causes as well. So the patient have different ways of expressing their symptoms. But if they say sore throat, don't take it as tonsillitis. If they have tonsillitis, you treat it, and then they are not sure, ask them to come back when they have a severe episode of tonsillitis, so that you should have witnessed an episode of tonsillitis. And then if they have few episodes, maybe 5 episodes or 6 a year, then they become a candidate for a tonsillitis. That's by the way. So because even allergy patients come with sore throat, people with obstructive sleep apnea, snoring, they also come with this throat discomfort and soreness, right? So you got to ask for those things as well. And the ear symptoms, sometimes the patient may complain of ear pain or hearing loss or itching. All are part of itchy nose, itchy eyes, itchy throat, the entire itchy spectrum, as well as fullness. Children come with discomfort. They may come with excessive crying and things like that. And as I told you, snoring and mouth breathing, again, that's because the allergy causes congestion and obstruction of the nasal airway, so that you tend to open your mouth. And the snoring is due to the upper airway obstruction, and mouth breathing because the nose is congested and obstructed. And if it progresses to the sinuses, you come with a headache and congestion. And the other symptoms, of course, the nasal symptoms which we have discussed. Okay, the next slide is not something that we really enjoyed at your medical school days. This is not something people like, but this is the cascade that you need to know. It's IgE mediated, which attaches to the mast cells, which releases all the histamine, leukotrienes, prostaglandins, which causes the immediate reaction like sneezing, itchy nose, and the runny nose and the blockage. And the B cells get activated, and then the other cascade comes in that causes the late phase reaction. So in allergy, there are two phases, the immediate and the late phase. So this is how it happens. Immediate phase is due to histamines and prostaglandins, leukotrienes and thromboxanes. When you decide on what medication you're going to use, this graph becomes a very important to cover the spectrum of problems. What you're going to prescribe. I'll tell you in the end how to go about this. Okay, how does this affect us? So it affects about 400 million people worldwide. So Indians have done a lot of studies. So they say it's the nasal symptoms are present in about 12.5% of the children aging 6 to 7 years, and it increases as the age goes up. Okay, so this is the classification of allergic rhinitis called ARIA, that is allergic rhinitis and its impact on asthma. So the classification, for your technical purposes, you need to know the classification. So it's classified as either intermittent or persistent, right? So otherwise you call the perennial rhinitis. So when you call it intermittent, it is less than 4 days per week or altogether less than 4 weeks. Persistent is the other way about. So the moderate to severe symptoms are when it affects your sleep or it impairs your daily activities, sport, leisure, or your work, and you have troublesome symptoms. So if it's mild, when it doesn't affect your sleep and you can do your activities normally like work, play, and school. So this is how it is. So that it can come with any combination. It can be intermittent, which is very severe, or it can be intermittent, which is mild, or it can be persistent, which is mild, or it can be persistent and severe. So you can ask them how much they're affected. If it's very short duration, the treatment is shorter. If it is long, then of course you have to, or if it is severe, you might have to add more than one in your armamentarium of medication that you are using. So it is not only allergic rhinitis, so you got to look for comorbidities that is associated in your history and examination. All right. So it can present with a common cold or a sinus disease like facial pressure pain, and it can aggravate the adenoid hypertrophy. They may present with snoring, mouth breathing, and obstructive sleep apnea. Eustachian tube dysfunction can present with hearing loss or fullness, and as well as otitis media with effusion. Some people do have those symptoms. Okay, so the other comorbid diseases that you see with allergic rhinitis is sinusitis, asthma, and as we told. And some people with nasal polyps. I know nasal polyps. Just a take-home message. If you look at your nose, you'll see the turbinates, the nasal turbinates. You have 6 turbinates on 3 on each side, inferior, middle, and superior. The inferior one is the one that you see. Most of the time, it looks a little pale and enlarged, so people tend to mistake it for a polyp. So polyp is pale and it's painless and it's pedunculated most of the time. It's like a rambutan mother, it's that color. The turbinates are different, so many people mistake it for a hypertrophic turbinates to a polyp. So you need to know. And then the septum is grossly deviated. Again, you see a thing, obstructing the nose. But you can easily palpate with a cotton bud or something like that. And then if it is firm, then it's a septum. If it's soft, then it's not the septum. Septum in the middle. These are on the side. So just to have an idea, what is a polyp and what is a turbinate. In children, you don't find much polyps usually. If you find a polyp in children, bilateral, it is cystic fibrosis, which is very, very, very rare in Sri Lanka. So I don't think it's more of a Caucasian problem. It's not ours. And if you see a unilateral polyp, in ENT, anything unilateral is something serious to worry about. Unilateral hearing loss, unilateral vocal cord palsy, and a unilateral polyp. You think of malignancies and things like that. In a child, if you see a polyp, it is not a polyp. Most of the time, you think about a meningoencephaloceal coming down. In adults, if it's a unilateral polyp, maybe tumor, maybe inverted papilloma and things like that. So anything unilateral, you have to worry. But if you're not very clear, if you don't need endoscopes to see the nose. If you have an otoscope, which you see the ear with, you can gently see what's inside the nose. You can just first have a good headlight. I mean, in the market you have all these everyday lights and things. That's good enough. You don't need a high-end headlight. You don't have to invest a lot. Just a good have a headlight so that your hands. That's more important. And then just lift the tip of the nose. You can see what almost halfway through the nose. You can see a lot of things. And with your otoscope, you can gently go in and see. And that's it's much easier, but make sure that they don't have cough, cold, or fever. Don't go too close, right? And because of the flus and things like that. But if it's a good day, you may be able to see something more with the little things that you have. You don't need to have a lot of things. And if the nose is blocked, they say to see the nasal airflow, all you need is a tongue depressor. Just keep it in front of the nostril and ask them to breathe. The misting, if it is there, then you know it's not blocked so much. It is not. In children, sometimes they may come with blocked nose, corneal atresias and things like that. So you have to make sure. So just a misting test is okay. So you can do. You don't. I mean, ENT has all high-tech stuff involved, but for your clinical work, you don't have to invest much. You just have a good light. An otoscope is important. And a few things here and there, tongue depressors and things which you can roughly manage your clinical setting, right? So that's why ENT is all interrelated. So allergic rhinitis can present just with the nasal symptoms, or it can have all the other paraphernalias that I was talking about. This is a very busy slide. Don't worry about it. So most of the time, the rhinitis is due to a virus, which is the rhinovirus. Okay. Okay, let's go to the common allergens, right? So many people say people are allergic to dust. It's not really the dust. The house dust mite, right? Is that organism that you shed, this fellow, right? That's the one. So how to get rid of it is you need to either put it on a washing machine or ask the patient to dry their bed linen once in 2-3 days out in the sun, right? And then grass, tree, and weed pollens. Pets, cockroaches is a main issue. You don't see the cockroaches, but you know it stays under the slab, so their existence causes a lot of allergy. And then if the patient is not settling down with your treatment, ask about the room, whether there are moles on the walls. That also adds to the problem. Right. Okay, so allergic rhinitis diagnosis is more clinical, history, and history. So these are the symptoms which you all are very much aware of. Okay, right. So you can ask the pattern of the symptoms, either it is seasonal or perennial. Seasonal is if they have it during some season or part of the month, and then they don't have on the other days. So that has a definite trigger coming from somewhere. Perennial is there throughout the day, throughout the year. That means something that's happening in your either the workplace or home where you live. So you can ask whether it's aggravated indoors, outdoors, right, or any specific triggers, and the tobacco smoke, active as well as passive, right? So if somebody has allergy to aspirin and things like that, that is another problem called Stammer's triad, which people have allergic rhinitis, nasal polyposis, aspirin allergy. Okay. So in the history, got asked about previous response to medication and the other comorbidities and a family history of atopy. Right. So a little bit more on this allergy thing. Allergy starts from your childhood, right? So children present with diarrhea and various things. Sometimes if you start on formula feeds very early, their gut is so porous, these proteins go in and act as allergens. So they become, they have diarrhea and other things. Then it may present like with an atopy rash, and it can present with rhinitis, or it can present as asthma. So it's a spectrum. You can be at either end of the spectrum. Okay, so physical examination, this is what I told you. Because the septum, the turbinates, the characteristic of the mucosa is more pale, and look for sinus tenderness, and look for the ears and the oropharynx as well. And of course, as I told you, lungs to diagnose concomitant asthma. Okay, so what are the tests? Okay, what are the tests that you need to do? This is very clinical diagnosis. I don't think you need to spend more money on testing. So but there are tests available that is for selected group of patients. If they are not responding to your treatment, whatever you give the patient is not responding, or you're not sure about the diagnosis, then of course you need to do. So there are two types of testing. One is the allergy skin test, right? You can do the intradermal or percutaneous scratch test. That is this one, right? And otherwise, you have to go for in vitro IgEs, that is the blood test. That is, you can either look for total IgE, and if the score is very high, then you have to go for specific panels. Any idea where they do these things? I don't know anybody doing in this area, but Kalambu Javadanapura, I think Professor Jeevan, he does that, and a couple of places in Kalambu. So they do all these tests. It's done by the immunologists, not us. So it's a different specialty. So they do the allergy testing. So you need to have the specific allergens, and they have the workup. So if patients are not responding, then you can send them. The blood test, the total IG doesn't say what you're allergic to. So you go for specific panels. Those are very costly tests, so that's the problem. But if you have a patient who can afford it and who's eating your brains, right, saying that, okay, doctor, this is not working, why, what's happening, then you are justified in sending them to an immunologist for these type of tests, which are done, right, but they are costly. But if the main problem why the medication doesn't work is compliance. So see whether they are using it and the technique of using it. Nasal sprays, if you just give the nasal spray, it's not good enough. They have to use the spray. It has to hit the sides of the turbinate. That's the area where your allergen things are working. So use the right hand to the left side, left hand to the right side. So his hand is already crossed. So you can't spray this way. So that's the technique. So if they have a lot of allergy, the other good thing is nasal douching, nasal washes. So what I tell the patient is, you take a glass of water, lukewarm water, boil cool water. Don't ask them to take just the water and to heat it to body temperature, because if the water is contaminated, you'll be injecting things up. It's going to be a problem. So boil cool water, heat it to body temperature. Put 2 tablespoonfuls of salt and a bit of baking soda, mix it, take a syringe, and then they're going to go in front of the sink and then press it on the nostril. And without allowing it to go into the palate, they say, the palate closes. Then it washes away, and do this. So that works wonders. It washes away the allergens, and also it helps the mucociliary function of the nose. So it's very simple stuff, but it works very well. And after nasal surgeries, anyway, we ask them to do those things. And there's another brand called Ocean Wave. It's come in a ready-made pack, which is expensive. But then if you can buy that container, rest of the things you can make by your own at home. Otherwise, your patients can do this little glass of water with 2 tablespoons of salt, a big glass, 2 tablespoons of salt and a bit of baking soda, mix it, and then you can wash it, which washes away the allergens and then removes the bad smell and things like that. They help, which is very simple. Okay. So how are you going to manage your patient? It's a triad. The main thing is the environmental control. In children, if they are allergic to many dust and things like that, at school you can't do much, but at home they can do all these things that I was talking about. And medications, and at last is the allergy immunotherapy. Okay, so if there are molds, then of course you need to have a very dry indoor conditions, and there are other methods. And then cockroaches, of course, you got to eliminate. Pollen, you got to see what is causing it and then avoid. And pets, of course, they say remove the pet from bedroom, or even better from the entire home. But if you want to put your cat out, the cat might say this. So you see, you can't put the cat out if you're a pet lover. You need to have the pet inside. So things like that are suggested, but then again, okay. So this is for the house dust mite. Okay, so you have a patient with allergic rhinitis. You want to give a nasal spray, right? What would you recommend? There are so many varieties. So the studies show the safest is budesonide, right? Budesonide is recommended. It's a bit more potent, but then it's tested and safe in pregnant women. So more than -1 and fluticasone. But if they're using it, there's no harm Most of the sprays are safe in pregnancy. We do give, but budesonide is safer in pregnancy. That's what it is. Okay, that's just a take-home message. So this is the one that we spoke about, and a little bit on acute sinusitis. What percentage of acute sinusitis is viral? About 80% is viral. So that's why in other countries they just treat with paracetamol and things like that. But then to prevent a secondary infection, we do treat with antibiotics, which is not evidence-based and justified, but still we do it. That's the honest truth about it. Okay. So this is I'm not talking about allergic rhinitis. I'm just talking a little bit on sinusitis. I'll come to allergic rhinitis treatment and tell you how to go about it. But I just want to cover a bit of sinusitis with allergic rhinitis because they all come together, right? So the major symptoms are the pressure of facial pain, congestion, nasal obstruction, discharge, purulence. Some people do complain of reduced sensation of smell, which is hyposmia, or no smell is anosmia, and fever. The minor symptoms are the ones that are mentioned here. Okay, so how are you going to diagnose sinusitis? Clinically, with this you can, right? I'm just going to show you a little bit on a CT film. So if you look at the CT scans, this is the sinuses should look like this, filled with air, right? You can see them. Right. I don't see. Okay, so it should be filled with air, like the black sinuses, right? So all the sinuses are filled with air. But if you have sinusitis, it's going to be like this. It should look like this. So if they have symptoms, then of course, if they are not responding, then we go for an imaging. Imaging of choice is CT scan. X-ray sinus has not been done in UK after 1986, but still we do because to have a spot diagnosis, and if there's fluid level, we know it's sinusitis, so we can treat and then follow up with CT. That is because of the financial constraints, but otherwise CT scan is the diagnosis tool. Okay. So this I'm talking about acute sinusitis. This is for your general clinical practice. So if you suspect with sinusitis, amoxicillin alone is not good enough. So you need to go for something. I see many GPs prescribing azithromycin. I have nothing against it, but it doesn't work much because we see the followers who don't respond. I mean, it's easy, it's single dosage and things like that. If it's just a viral thing, you get away with it. If it's a bacterial sinusitis, and if the patient can afford it, going for a co-moxiclav is better, right? Or else second generation cephalosporin. But in my practice, co-moxiclav works much better than the other stuff. The cost is not much if you think about the work lost and again having to come to see someone. So think about it, right? Azithromycin doesn't work much. I mean, it's there in the literature, they give it, but we see most of the people who fail. So we know that they have been treated with azithromycin, which doesn't work much with this. So it's a second choice, which is clarithromycin. That works better on people who are allergic to penicillin. Of course, I am a bit wary of giving a cephalosporin because you can get a cross sensitivity about 50 to 75%. So better to go for something safe. You don't want to give an allergy to the patient after having said that the patient is allergic. So better to go for a clarithromycin sort of a thing than to stick to something because you have a choice. Somebody asks why you didn't give it, then you have no excuse. So you can try a clarithromycin as a second choice. Okay. Backups, quinolones, that is ciprofloxacin and stuff, they also work, right? If it is a dental origin, then of course anaerobic, then you have to go for a metronidazole. But otherwise, amoxicillin basically covers, co-moxiclav covers most of it. So if you give it, if you have given only one drug, this is much better for your practice. Okay, right. So other tests, well, it's more clinical, so I don't want to take your time. And then having spoken about allergic rhinitis and acute sinusitis, you need to know the complications of acute sinusitis, especially in children. They are the group that can suddenly go either way. If they improve brilliantly well. If they don't, they deteriorate very fast. So with acute sinusitis, you get basically in children. Right. One more tip I want to tell you people that the frontal sinus doesn't develop up until about 6-7 years of life, and after till about 11 you don't have a fully developed frontal sinus. So if you have a child complaining of sinusitis here, it is not sinusitis. Remember that. They don't have frontal sinus. But anyway, we do see people querying sinusitis. But if you ask Lakwan, you will know how many X-rays we see, and most of them are, they don't have a sinus, but the referral comes as sinusitis. So when you're born, you have your ethmoid sinuses. Ethmoid sinuses are the sinuses that are between your orbits, the honeycomb-like thing. Maxillary, you are aware of. Frontal, these are the ethmoids, right? So the sinusitis goes to the ethmoids first, and then if the body fights, then everything is fine. If they don't, they go into the orbit. From the eye, there's a bone called lamina papyracea, which is it's papyracea is called like paper. In the Egyptian term is papyrus, right? It's like a papyrus leaf, very soft. Even in surgery, if you just touch it, you are in the orbit already, which is going to cause complications. So it goes to the orbit first, and then you come with a little swelling in front of the upper lid, which is called pre-septal cellulitis. Then it goes a little behind, post-septal cellulitis. Then it goes under the subperiosteum, called subperiosteal abscess. Then it goes to the orbit, it's called orbital cellulitis. So if you think about the orbit, it connects directly with the cavernous sinus at the back. Then it comes for cavernous sinus thrombosis. Then both the cavernous sinus are connected. Then it goes to the other eye. So you become blind in one eye, and then you lose the other eye. So it's a side-sailing thing. It's a huge thing. An ethmoid sinusitis, an orbital cellulitis, right? So if you see a lid, but if there's an insect bite, don't get very alarmed, right? So if you were to go with the symptoms, but you're a ruler, even with an insect bite, you can get a little bit of swelling. So this one, we had this interesting child referred to us by the ophthalmologist. So this child had an upper respiratory tract infection, then again came with this swelling. I didn't put the CT because it's complicated, but the child has had ethmoid sinusitis, and it didn't have a very well-formed abscess, but clinically, the eye, if you see, there's proptosis. Eye is non-axial proptosis, eye is gone to one side and it's coming out, right? Yeah, it's a child. So what we did with the CT, and then we drained it. I went intranasally, cleared the ethmoid sinuses, and then the ophthalmologist joined me, and then we drained. We went through an incision over here, and then peeled the periosteum, and we drained a little bit of abscess. Then that came out, and then I put a drain. So, and we thought, okay, we all are fine. But after a couple of days, the child again, the vision was 6/60 when the child came, but then after that it improved a little bit. The child could open the eyes a little bit, redness reduced compared to what it was, if you could see. So I was a happy man for a day or two. Then again, what happened? The child didn't improve, deteriorated. So we did another CT, discussed the CT with the radiologist. So there was no abscess on the outside, but there was abscess collected inside the eye. So it was an orbital abscess. Then we connected with the oculoplastic surgeon. So this is the orbital abscess. So he came and helped us. So he went transconjunctival, lifted the medial rectus, and then went and drained the abscess from there. So then, managing the patient was easy, but managing the parents was not very easy because, so that's the time you need to have the resilience, the confidence, and you should have a team. It's always good to go to jail with somebody else, not alone. So always refer. And this is how the Western world does medicine, right? Here, the referral system is, sometimes it can be a little dodgy. People don't like to get opinion. Sometimes they think that, okay, I know it all, but that doesn't work that way. So if you have somebody, who's an expert in the adjoining field, get them in. So then their advice is extremely helpful. So Tavisha brought Masika. So he came and helped us. A very nice gentleman. So we had a good team working. So I could tell the mother, okay, I've got the microbiologist in, I've got the oculoplastic surgeon in, I got the ophthalmologist in, and then the whole team and the radiologist in. So it was a matter of coordinating. So then we persisted, and the child improved, and that's how he went home. So this is not easy. So must thank Lakwan and the team. Yeah, they did a great job with the patient. So it's very nice to have a very good team to work with who understand what's going on and how to manage things. So it's really nice when you have difficult cases and how to go about it. But so allergic rhinitis, then again sinusitis. This is what you should not miss. Somebody coming with a bit of a swelling, especially starts with the upper leg. So ask for them, and you are justified in asking for a full blood count and a CR. Don't keep your threshold very low for a blood count as well. Go for a full blood count and a CRP, because that will save the day. If the indicator is going up, then you know things are not good. Then you can tell the mother or father, this is what it is. So in your clinical practice, and then don't be shy to review them. Ask them, give them a free visit, right? If you are not sure, safest thing is get them back. Say that even open access, say come back. That's what we do in the practice also. Say if you're not, things are not going well, you say come back anytime, we'll have a look at you, right? So then they have the confidence, they will come, and then you repeat the blood. Then don't lose the patient saying okay. So otherwise they'll go to somebody else and start from the scratch again. So that person to recognize is going to take time. So and it's not good for you or your practice or your confidence. So on that, a blood test helps. So that also you need to have in mind, and also imaging. CT is just like an X-ray now, right? So you have to have it. So at the hospital practice, so we have a very low threshold for that as well. So that and we have a good team supporting at Sirimavo. We are very lucky. Unlike other hospitals, which you all must be aware how difficult it is to get a CT for. Even if your wife falls ill, you take, there are no appointments, right? So that's how it is. But it's not everywhere. But these guys are really helpful. So it's good to have a good team with a good attitude. So that and we have a pediatric radiologist back in Sirimavo. So she's board certified as a pediatric radiologist as well. So we have 3 people. So they all are helpful. So new fields, new things coming up. Just for your awareness that there is somebody called a pediatric radiologist as well, like the pediatric nephrologist and the neurologist. They're always certified in that. So really good. They give all minor details, and it's nice to discuss. So and other thing is go and discuss. If you have a patient, if you have anything ENT, please come. Bring an X-ray, bring a report, talk to us. We are there to help, right? So don't worry. Okay, so when the acute sinusitis becomes chronic, what are you going to do? What's going to be your treatment plan, right? So what's the antibiotic? Basically, if the things become more chronic, I stick to a ciprofloxacin because it's cheaper, right? And you can give, the treatment is prolonged. Not in children because of the epiphyseal growth and things like that. I'm not very favorable with ciprofloxacin unless it's recommended by the microbiologist. So okay, in acute and chronic sinusitis, the nose is blocked, we can use decongestants, right? Like oxymetazoline and xylometazoline. It comes in many names, like you might know Decon, Nestibion, and various things, right? So that works wonders. Patients love that, but the problem is they get addicted to that because it just brings vasoconstriction. So it works much better than any other medicine you are given for nasal congestion. So once they use it, they think, aha, this is the drug. But what happens is it produces rebound phenomenon, which is called rhinitis medicamentosa. So you can give 3 days, max 7 days, don't go beyond that. That nasal spray you can use for about 7 days, 3 times, but other drops maybe about 5 to 7 days and not more than that, right? So otherwise they get addicted and they always carry one with them, you know that, right? So if you want to get them off, then you have to put them on steroids and taper it and then go with the steroids. So the topical steroid is the drug for most of the things. So one thing I want to emphasize with nasal decongestion is that, okay, right. So when to refer? Complicated patients, severe symptoms, or they are not responding for initial therapy. So otherwise, if they have underlying atopic disease or recurrent sinus infection or symptoms persisting, and then you need to. So the non-responders to initial treatment or recurrent infections. Okay, so you need a team, as I told you, sometimes ophthalmologist, sometimes neurosurgeon, radiologist, the neurologist, depending on the sectors. Okay, so serious complications need hospital admission, as I told you and as I have shown you. Okay, But I haven't told you how to manage allergic rhinitis, which is what you want, isn't it? Okay, so this is what it is. If the symptoms are mild, right, and it's intermittent, so not bothered much about it, you can use a H1 blocker antihistamine, right? An intranasal decongestion, less than 10 days. If it is very acute, you can use xylomethicillin and Ditoray with an oral decongestion. And then, of course, the bottom line is allergen avoidance and the irritant avoidance. If the symptoms are more like moderate to severe, then you need to go for a nasal steroid. Okay, one thing about nasal steroid, the drops or sprays. This is what do you prefer? Drop or spray? Okay, this spray. Okay, the problem with the nasal drop, right? The steroid drops which you use, the betamethasone drops, right? In other countries, they don't allow you to use for long, not more than 2 weeks, but we go for 4 weeks because you can absorb it, and then people get this hypophyseal axis can get affected because of the systemic symptoms. Some people put on weight, so they consider it's like a steroid oral thing because they can swallow. So most of the time in our practice, we use the nasal drops for, especially if they have adenoid hypertrophy. It doesn't reduce the adenoid, but it helps the turbinates and the congestion, so the breathing space becomes better. So for a month, and then we go for a spray. Spray doesn't have systemic effect, so you are justified in using longer. There's no problem. Patient doesn't die. But of that, mometasone is much better. Then the fluticasone. After that, budesonide. Betamethasone is not. It's more potent, so you have this absorption effect. So the drops are not very safe to use long term. Many people use one drop. One drop doesn't reach anywhere. It's as good as not giving, right? And the child doesn't allow you to put the drops. And then even adults, right? There's a way of putting it. The drops, you have to be in the prostration position or like extended. I don't think anybody will do that, right? So sprays are much easier in technique as well as the efficacy. But of course, it's more costly. But if you are giving for a month, then sprays are much better, right? So that's about the drops and the sprays I want to tell you. So you all use the nasal drops, betamethasone, but then don't go long term. One drop doesn't work. At least 3 drops you need to use. But that's off license for a month, but we do use it. That's the practice we have, right? Okay. Then there is this local the intranasal antihistamines, Azilast, right? It comes, I think, there's one company marketing it with fluticasone. So if you have these itchy symptoms and all, the intranasal antihistamine, that works well for some people. Some people don't tolerate it because of the irritant and things like that, but many people say that's better, right? So that is the other one. So if the severe symptoms, of course, then you have to do everything and go for immunotherapy. So that's the last resort treatment. Immunotherapy is basically you get your body to get used to it. There are several types of immunotherapy. One is sublingual, other one is the intradermal you can give, or you can give intralymphatic, but many people go for sublingual immunotherapy. That is, they identify the allergen with skin prick test or the blood test, and then they give you it in incremental doses. It's a long process, takes about 2-3 years, costly matter. And if you are allergic to a single agent, it works. Multiple polyallergens, it's a bit tricky, but that is what it is. So, so when people come and trouble me a lot saying this didn't work, that didn't work, especially the younger generation, the next thing is the monoclonal antibody, one MAB. That is the antibody that just stops the IG. I tell them, you guys become scientists and discover this faster for clinical practice. That is the monoclonal antibody. If it comes, it will be a breakthrough where it stops the pathway from right on top so that it doesn't escalate so far. So these are the pathways to block, which you use the mast cell stabilizers in the leukotrienes and antihistamines. So if you can block it right in the beginning, that will be the breakthrough. We have it's on trial, still waiting, but still not in the market. So antihistamines. What's the antihistamine you would like to use? You have so many, right? You have so many antihistamines. So right. Well, the cetirizine and things, the drowsiness is a problem, right? And chlorpheniramine, that is the pyriton diamine hydramide, those are the first generation ones. They have sedating effect, but they work very well. But of course, they makes the patient sleepy. So many people don't like it. So cetirizine has this problem. So the other ones is the loratadine, there's loratadine. Then some literature says fexofenadine is much better because it's non-sedating and longer lasting and things like that. So there's something called rupatadine that has come into the market. So those are the antihistamines that we commonly use, right? And what else I want to tell you? Okay, so the nasal sprays, even children are about 2 years, you can use the mometasone nasal spray. That is the sprays. There are a few in the market which you can use. Otherwise, in smaller children, only mometasone is advised under 6, which works well. So what else I want to tell you? That's all. Yeah. So people say, okay, why or you use first generation when the second ones are available? So okay, going back to the history. So the first accurate description of this allergy was described by 10th century physician Rhazes. Okay, he identified pollen as a cause, and then Blakely, and then 1966 Clemens propagated it. So and then it grew, the field grew. So the name allergy was coined by the Greek term allus and then ergon. So that's the history. So to conclude, allergic rhinitis is associated with several comorbidities, and the risk factor is asthma, which affects quality of life. So people tend to go away from first generation to second generation antihistamines, and then of course nasal spray is the building block which adds to the armamentarium, and you teach the patient how to use the nasal spray, and you can so. If the symptoms are very worse, you can give an course of oral steroids, right? But be careful in using in the 9-10 years when you give steroids, is birth diseases and stuff like that. Otherwise, so I'm not very happy to use steroids on that age group. But in adults, yes, if the symptoms are worse, a short course of steroid works. But then they buy the same medicine, dexamethasone, they buy from the pharmacy, right? And then that's when they fall into trouble. So you have to make sure that they don't repeat it because they become, side effects. So you can start with steroids. The symptoms can go from low to high or high to low. The symptoms are worse with steroids, nasal decongestion, with the xylometazoline, so that as this for things to allow to go in, and then you can top up with the steroids, give antihistamines. Montelukast, yes, if the symptoms are very severe, but then when you add so many, it's going to be costly as well, right? So you have to think about that as well. So with that, I conclude, and I thank all my teachers and patients who taught me all that I know, and I'm where I am because of my patients, my teachers, and good colleagues like you. And Asanka, you gave a lot of anesthesia when I was registrar, and evenings we used to do a lot of surgeries. So without a hesitation, I got so many of them, and who have encouraged us. And I know from my demonstrator days, Idesha and husband, seeing him after decades. So it's all nice to see everybody. Thank you very much for your patient listening. And if you have any questions, I'll be very happy to answer. However stupid it may sound, please ask. It's okay. Right? That's how it is. Don't be shy.
A lot of us, doctors advise patients not to touch water, not to touch cool things, not to drink cool things, not to have bath, and even not to have water.
Yes.
I have seen, but what is your advice on that?
See, this is this whole thing, this sema pitta thing, you see, so that has, in some patients, it has a basis. I'm not saying no. But Sitala Kandepa, Nandepa is a very broad term. So if you're allergic, if some people, the symptoms worsen, the allergic rhinitis, some people with migraine, if they don't dry their hair, they do get it. So it's a trial and error. You need to find out what is making things worse. Food also, it's not like you're not allergic to everything. Ice cream doesn't make you, So I tell the patients, you try it. Even the migraine patients, you got to tell them, okay, you know, if the triggers can be the sweets, the dairies, nuts, or Ajinomoto containing food, anything. So, but you just tell them the spectrum, or I mean, if they don't eat the meals on time, don't take water, if they are stressed out, breaking sleep, or some smell, perfumes, right? So the stress with periods. So you tell them, okay, these are all the things that you should consider. You try. It's a trial and error. First or second month, it's going to be a bit difficult for you to put your finger on what it is. But then, otherwise, if you give a blanket statement, uh, it's not correct. But then, if the mother is so convinced, and if you say, then they don't come back to you. You see, so you got to play according to the pitch also. Some people have a very strong belief in it, so then you can't uh, refute that. So, but you tell them in a different way to look for the allergen, because the fellow will anyway have, if they have pocket money at school, he will have an ice cream or a cool drink. I tell them, okay, amma dakinattu bondaki, amma missalaki. So that's how you go. Then the patients are very happy. You see, but I agree with you. Yeah, there's no basis as such, but in some, yes. So it's not a total yes or no, but most of them are not allergic to most of them. The allergens are these molds and house dust, mite. Those are the things. Yeah. So those are the patients. If they don't respond, you need an allergy testing. But that's costly. That's the problem. You do the full panel, it's going to cost a lot. And they do the basophil activation test as well. They can do the nasal challenge, but everything is, and this is not a life-threatening disorder, you see. So then again, so people, I don't think they will see that much of treatment unless somebody is really, really worried. Then you have to refer, but not all.
Do you recommend the use of multiple antihistamines with viral symptoms?
I mean, you all are very familiar with seeing these prescriptions, right? They have one PPI for the morning, one PPI for the evening, one antihistamine, another antihistamine. That doesn't have any rationale. No, I mean, in Sri Lanka you can survive, but not anywhere else. No. But if the patient is having severe symptoms, has something to perform, a bit of steroid will help. But if it's a diabetic, for a couple of days you can come by, like just to say somebody has an exam or something performing or something important coming up, an interview, then you can coin two different ones, the first generation and second generation, with the sedating ones at night, the non-sedating ones in the morning. You can do that for a few days, but if you prescribe for a month, then there's something wrong somewhere. That means you have not diagnosed the problem. Ask them to use the spray properly, it works. If the spray doesn't finish, that means they're not using it. So most of them use it as and when necessary. They think it is an acute remedy, the steroids. That is when the steroids don't work. Otherwise, it should work. Get them back, see how much it has finished, and then advise them.
Is there a place for surgical management?
Surgical management, well, you can't stop the allergy with surgery, but if you have an obstruction, right? If the vastly deviated septum or very big hypertrophic turbinates, or if it's an adenoid, you can give some space, but you have to tell the patient the target is to reduce the nasal obstruction and not an allergy. Otherwise, after surgery, they will say the sneezing, runny nose, itchy nose, so then again, so that means you're not explained. So I don't offer surgery at one go. I tell them point blank that I will not be able to cure these symptoms. This you have to persist with the spray. The obstruction, yes, we can relieve, but as well in children, it's limited surgery, not a lot, because it affects their facial growth and things like that. So with the septum, but turbinates, you can reduce the turbinate. There are so many ways of reducing the turbinate. If you overdo it, it will cause crusting. Then the crust accumulate bad smell and things. It's a social problem. So you have to be a bit careful, but you can do. But those are for obstruction. And there was a surgery prescribed called video neurectomy for vasomotor rhinitis. That is not the allergic rhinitis. And now they call it the posterior neurectomy. But those things also can be managed with medication. So surgery is to help with the other concomitant problems rather than the problem per se.
When there are polyps, then we can see when there is polyps.
Yeah,
Is it management?
right.
What is that?
No, see the polyp in medicine, there are certain diseases which are medical. So I also learned it as I went along and learned it the hard way. Say sometimes if people come with diabetic patients coming with otitis externa with osteomyelitis, called malignant osteomyelitis, right? It is, because it behaves like malignancy, called malignant osteomyelitis and called osteitis basically. So those people go up to facial palsy and things like that. Unless there's pus or necrotic tissue, it is a medical disease. So you've got to tell the patient this is a medical problem, not a surgical problem. Many people will say surgery karamod scan shows this, that, and the other, and then you end up in a soup. The patient still discharges. So it's a diabetic control and infection control, which is so likewise. The fact that you form a polyp is basically the allergic mucosa that is bulging out. I tell the patient, I show them if I'm wearing the glove, I tell them the glove, I enlarge it, doesn't have weight, it just comes through the finger. Likewise, the polyp comes. So the reason the treatment of polypectomy, which is now with the surgery, endoscopic sinus surgery, clear the polyps, that is allowing the medication to get into the sinuses where the polyps are coming from. So if you do a thorough nasal polypectomy plus endoscopic sinus surgery with ethmoidectomy, middle meatal antrostomy, Wazeer antrostomy, sphenoidotomy, and the full house, and the patient doesn't use the spray, in 3 months he comes with the same polyp. So don't offer surgery at once. See whether the patient is compliant, taking the medication, taking the douches, and the patient is sticking with that. Give up and oral steroids. They're not diabetic. 7 days of high dose of prednisolone works like surgery. It reduces most of the polyps. Patients are better. They can smell better. And if they're not symptomatic, don't offer because you practically can't remove all the polyps. Because there are so many sinuses, they are close to the skull base, close to the orbit, close to the carotid artery and the sphenoid. So it's a mess. We don't like to operate on polyps basically because there's no end to it. The patient is not happy. They come back again. Then you have to do a navigation guided full house fest again if the patient doesn't use, because the medical problem is the allergy. That's the basis. So if you can treat with medication, and if it's a diabetic patient, sometimes we admit, get a good diabetic control with the physician or the endocrinologist, give the steroids, they do well. That's less complicated. But if it is very big polyps, they can't breathe, doesn't, then you have to do a debulking and allow things to go in. But if it is surgery, if you have worked in ENT units, you know how many times they come back. It's very frustrating. So it's a medical problem which you are trying to treat surgically. So there are certain diseases which are more medical than surgical, which you need to pick and select. It's like playing a game of cricket or tennis. It's a shot selection. You put the bat outside the off stump, you're going to get an edge. So it's to pick your cases, pick your fights in life. You see, so you need to let go of certain things, right? The mother will come and bother you so much, but then you need to have a conversation script how to get out of the situations and tell them, right? Doesn't matter they go to somebody else, they get operated, does not matter. As long as somebody's shouldering your burden, you are a happy man, you see. So refer those cases to your worst enemy if you have one. Yeah, polyps, you never get a happy patient. Single sinus obstruction, super. You can do a nice surgery, you enjoy your endoscopy, or you can show your junior colleagues, I'm seeing this sinus, that sinus, but they're not on this polyps. It's a mess. Yeah, it'd be like entering a war zone. No anatomy, nothing you can see. Hungry? Okay, thank you once again.
Thank you, Dr. Saffrullah, giving us a very wonderful lecture, effective management of allergic rhinitis. I call upon Tiran to give a word of thanks.
Good evening, everyone. As we come to the close of the insightful and enriching session, On behalf of CIPLA, I would like to thank firstly Dr.Saffrullah Wazeer for accepting our invitation and coming here today and delivering the speech. And sir, definitely, I think your expertise and detailed presentation have provided with valuable insights and practical strategies to better manage allergic rhinitis. Also, I would like to extend my appreciation to all of you because for your active participation with this short notice. And also, I would like to thank Team Opera and also thank you once again for the participation and hope to see you all in the future meetings as well. And I would like to invite you for the fellowship dinner. Thank you very much.
Ready to go. Don't worry.